Well, hello. My name is Nilofer Azad, and I am a medical oncologist here at Johns Hopkins University at the Sidney Kimmel Comprehensive Cancer Center. I have been focused on taking care of patients with colorectal cancer for the last 15 years, and I'm very happy to be here today with Cancer Nursing Today as a roundtable to focus on colorectal cancer with two of my colleagues, Rachel Klein, who's a nurse practitioner who works at Johns Hopkins as well, and Fatemeh Youssefi, who is also here representing nursing that takes care of colorectal cancer. When we're trying to make a decision about first line therapy, what are the things that you are taking into account as part of the care team when we're talking to a patient about FOLFOX, FOLFIRI, FOLFOXIRI? And then we also haven't yet mentioned capecitabine-based therapy, so you can give capecitabine and oxaliplatin, CAPOX. So let's first talk about the cytotoxic chemotherapy. How do you choose? Those are the 4 regimens that you can use in the first line. And sequencing wise, we usually do one and then we do the other, right? So you do oxaliplatin-based therapy and then irinotecan-based therapy if you don't do FOLFOXIRI in the first place. So how are you helping patients and the providers together choose CAPOX, FOLFOX, or FOLFIRI? Or the triplet. Fatemeh, how about you?
Well, I
What
think
things are you taking into account?
so. I think when you talk about capecitabine, the adherence to the medications becomes very important because that means that they're going to go home on a chemo pills that they need to take for the next 7 days, 14 days,
Absolutely.
whatever the regimen is being prescribed. And to understand that patients has the resources first to obtain the medications and to be able to adhere to it, to understand. And again, I like to always go back to health literacy for the patient to be able to count. You need to take 3 in the morning or 2 in the afternoon because all the time capecitabine is based on a body surface area and is not always is the standards of quantity. It may be 3 in the morning, 2 in the PM. So for the patient to learn and to be able to take those medication on time and be able to communicate if they have any side effect to the providers. And also, just on a caveat, on a side, chemo handling is a big deal when the patients have to be home. If they have a minor child, that make sure that chemo pills, or if there is a pregnant spouse, they know they're not supposed to touch that. So that goes with any oral adherence. When we're talking about the understanding such a thing like oxaliplatin, if this patient again is diabetic, it's very important to bring the teaching is that this can cause neuropathy. How do you need to handle it? At what point to report the side effects? And that goes also with irinotecan. If this patient doesn't know as what time to call the providers to say, you know what, I have continuous diarrhea or my ostomy is getting full more than usual, what do I need to do? So I think those are some of the elements, and for the patient to understand again at what point to communicate that help with the selections of the regimen.
I think the diabetes part is an important thing to mention also because we often give steroids with our regimens. And so that can also increase and change people, and they need to be able to handle that, right? And so part of care coordination might really also be working with the patient's primary care physician around diabetes management as well, since we give steroids, high dose steroids for the first few days after chemotherapy as well. And then I think importantly, we have to also make a choice about targeted therapy options. So are they going to get bevacizumab, or are they going to get an EGFR inhibitor, cetuximab, or Erbitux, or Vectibix, which is panitumumab? Which of those are they going to get? Again, assuming their molecular profile allows them to get that. And so, Rachel, when we were deciding with the patient, we talked about left versus right-sided disease, but let's say you've got a left-sided patient. What are you advising them? How are you counseling them about whether they should do an EGFR inhibitor or if they should do bevacizumab if they have RAS-RAF wild-type disease, meaning no mutations?
Well, first, I would say I don't think there's a wrong answer in the sense that whatever we don't use now, we might use in a future line of therapy. So I like to just reassure people that even if we start, if they want to minimize all of the side effects that they could potentially have, not pile everything on all at once. We can, if they don't want to use a EGFR inhibitor first line for any number of reasons that we'll talk about, they could use it in the future potentially in a different combination. But certainly the primary side effect of the EGFR inhibitor is a rash, right? The epidermal growth factor receptor inhibitor. So it causes a really potentially very significant, very visible, very uncomfortable acne-like rash that often is on the face, scalp, chest, back, any kind of sun-exposed areas get especially affected. We might consider the weather, honestly. We might consider the patient's occupation, whether it's primarily outside and they're planning to continue working. We might consider whether they have a very visible public-facing job and whether they're willing to risk having that rash. But we certainly would counsel them on the potential benefit that it could also offer them in providing, overall response to their tumor shrinkage and their survival.
No, and I also think it's important that people understand that if they get doublet therapy, EGFR inhibitors are better than bevacizumab if they have left-sided disease. But if they're going to get triplet therapy with FOLFOXIRI, that has not been compared head to head. So you can thread the needle of not having to have the rash, which is what I often do in my practice, by giving them the triplet therapy with bevacizumab. Now they don't have a rash, and I'm hoping that their survival benefit will be similar, even if you're comparing across trials. So, but you were going to speak about bevacizumab-based side effects as well, or how you might choose bevacizumab.
Yeah, I think that's an important point, and I look forward to hopefully seeing that trial in the future. That would be a fantastic piece of information for us all. But with adding bevacizumab, certainly it also can increase our risk of complications. As Fatemeh mentioned earlier, it as a VEGF inhibitor, it can increase blood pressure. It can increase microvascular constriction. And so we worry about nephropathy. We look for protein in the urine. We potentially increase our risk of blood clots, which is already a risk when you have a malignancy. And it also may increase the risk of a bleed. And so we do, I think, have to be careful with our patient selection and upfront bevacizumab in patients who may potentially need an emergent surgery to provide diverting ostomy procedures, or who have had recent surgery, and we may need to delay our start of bevacizumab for patients who have had surgery in the last 4 weeks.
And I do want to emphasize that having a DVT or PE is not a contraindication to having treatment with Avastin or bevacizumab. That has been looked at. So even having a recent pulmonary embolism is not a contraindication. However, arterial thrombosis is, right? So if you have an arterial thrombosis, that is a contraindication, luckily much more rare. Fatemeh, anything that helps you make that decision between targeted therapy or help advise your providers about anything in particular about a patient's history that makes you lean one way or the other?
So, as a nurses, again, we allow for the physician to make a decision of what kind of treatment they're prescribing. But one thing that is important also that I like to emphasize, again, goes back to quality of life. If these patients is willing to come to clinic and wait and get their treatment 3 hours, 4 hours versus that 2.5 hours, if they're willing to come and have the urine test for the protein urine. It's amazing that how much patients are busy. They wanted to get on with their life, even though we're thinking that, they may have a good life for 3 years, but they want to go to visit their grandparents. They wanted to travel. At one point, those are making basically take a variable in this equation. And like with Vectibix, are they going to willing to stay to receive more magnesium if their magnesium is lower? Something that sometimes with Vectibix it happens. So all those talk and all those chemo teachings and immunotherapy teachings has to be played in advance, so patients know what they're facing rather than kind of surprise, you're getting this and this is how the sequence will happen, you go home. There is more to it in the background. So I think the good nursing assessment is important to communicate that to our providers, basically.
So I think it's very reassuring to hear how much commonality there is when we're trying to make these decisions. And so just as kind of a nutshell, to me, it appears very consistent that when we see a patient in the first line who is not a candidate for resection, curative intent surgery, we're really thinking of FOLFOXIRI versus FOLFOX-CAPOX versus FOLFIRI as the chemotherapy backbone. We're making those decisions really based on what things are important in terms of patient factors. So their molecular genetics will help with the targeted therapy piece, but we also want to look at quality of life issues and what else the patient is doing outside of having cancer, which is very important. And then we also are looking at targeted therapies with either Avastin or an EGFR inhibitor. That EGFR inhibitor is only available to the 50% of patients that are RAS-RAF wild type, and then only in patients who have left-sided disease. And then when we talk about sequencing in colon cancer is relatively simple because we do one regimen, and then for second-line therapy, we flip to the other regimen. And usually in between, we do maintenance therapy if a patient has stable disease.